Check 2. Joel, nice to meet you. Yeah. I'm going to place this a little bit higher so it picks up a little bit better. I'm just going to make sure we're capturing.
Okay. And, yep. It sounds like okay. That is plenty loud. Okay. That's cool. Can everybody hear me? I can hear myself. That's a little distracting, but that's
So, hi everybody. I'm standing in for Bill today. He's in Florida with his mom. And since I invited the speaker, Bill asked me to introduce him. So this is Joel Worrall. Did I say that right, Joel?
Yeah.
Okay. So Joel's the Chief Technology Officer at an organization called Cure International, and his title of his talk today is called HospitalRun: The Challenges and Opportunities of a Cloud-Based EHR in the Developing World. So Cure International has been around since about 1996, and they've been focused on delivering healthcare in the developing world. They operate hospitals and programs in about 29 countries and are focused on surgical care and specialties that include orthopedics, neurosurgery, reconstructive surgery, and maternity care. They treat patients in underserved areas where their physical disabilities can be corrected or alleviated through medical intervention, and they treat patients regardless of gender, ethnic background, or religious affiliation. Joel has a BS in computer science from Messiah College and a master's of religion in Old Testament and the ancient Near East from Evangelical Theologic Seminary. Since 1999, he's been working in internet-based technologies, delivering, supporting, selling software as an architect, executive, and consultant. As I mentioned, he's currently the Chief Technology Officer at Cure International and leads their marketing, technology, creative, and Cure Kids. Joel and his team are working on open platforms and open source communities to help pioneer ways for software and technology business principles and tools to influence the way charitable work is both conducted and supported. He's currently the project manager for HospitalRun, which we'll be hearing about today, and he lives with his lovely wife and 2 daughters in Mechanicsburg, Pennsylvania. And I know I'm also supposed to say there's a hashtag. If anyone's listening on the stream, they can send a question. Does anyone know what that hashtag is? DMICEConf, and someone will be monitoring it. Okay, thanks so much, Joel.
afternoon, good morning, happy March to everybody. Let's see if I'm not going to move my presentation there. I'm going to move it over here, and I'm going to run it. Let's see. Hopefully that's going to work out for us. Right, so as Steve said, presentation is titled HospitalRun, which is the open source project. We're running the challenges and opportunities of intuitive cloud-based health records in the developing world. Steve already said this, but a little bit about me. So I'm a coder, computer nerd, who happens to be working for an international charity and is found myself as a part of an open source project that's focused on health-based information systems. I am not coming in here as an expert, right? So like I'm a practitioner, I'm a student of all the things that I'm involved in. There's no cloak of authority like in this conversation. But I mean, we're doing some pretty interesting stuff, and I've been studying this work for 6.5 years, which is what I've been doing with my life for 60 hours a week. Okay, so just a little outline on what we're going to talk about today. I would encourage, recommend interruptions. It'll make it, I don't think I'm that interesting enough to listen to for an hour. I'm not sure if anyone is. And so feel free to like ask questions. If I don't want to answer it, I'll just say I want to talk about it later. Or if I just don't know, I'll say so. So we're going to go through, I do want to cover a little bit more about who we are as an international organization because it has a lot of bearing on the way we're approaching problems. Some analysis that we did around like existing options when it comes to what we could do for health record solutions. Go over some of the challenges that come about with trying to pursue more sophisticated technology solutions in developing world contexts. And then the opportunities, that's the flip side. I don't know if I'm an optimist, but I think this job's making me one, of doing this kind of work. A couple technical details. I'm not going to like drive down into the code, but like just kind of explain a little bit about how we're actually delivering the solution, and then just a little bit on early results. So for starters, Cure International as a platform for innovation. So this is a map of the locations around the world that Cure International operates. So we were started in 1996 by an orthopedic surgeon and his wife who, after coming into a significant amount of wealth, decided to pour the majority of what they had into the care of disabled children. And so they had done a lot of short-term work where the doctor had gone over and done a lot of like pretty sophisticated surgical care. Thought there were some pretty systemic problems with a short-term surgical model when it comes to like long-term follow-up with a lot of these cases that can be pretty complicated. I don't think any of us in this room would want the doctor that just operated on our kid to leave town tomorrow. So what would it mean to like really be more institutional about the way we approach some of these problems? So innovation's kind of always been a part of who the organization's been. Just as an example, so we've got hospitals in 10 countries, Kenya, Uganda, the Dominican Republic, the Philippines. We have a really strange scenario with a facility on the edge of Oman and the United Arab Emirates. Niger, which a very, very resource-constrained environment. Ethiopia, Zambia, Afghanistan, and then Malawi. We do more than that, though. We're also the largest provider of infant clubfoot care in the world. So I'm going to assume everybody has some sense of like what clubfoot is as a congenital deformity, and maybe we all know it's the most common congenital deformity in the world, completely treatable through Ponseti method. And so we run a network in 20 countries of nationwide clinics where anybody can go and receive care. Their kids can go through the casting process and wear the boots at night. And theoretically, like if you follow the treatment protocol, you're going to be okay. That costs us like maybe $400 to be able to take somebody who's going to live with a crippling disease and turn them into somebody who's never even notices the fact. In fact, it was interesting. Our chief medical officer had clubfoot, and it's so not a part of his life that he forgot about it until he started working for us, that like when he was a kid, he was born with clubfoot. So that's what we're trying to do for lots of kids around the world. We're also doing some really important work in neurosurgery, particularly the treatment of hydrocephalus. So our hospital in Uganda, in Bali, Uganda, I don't know this for an absolute fact, but it's got to be like somewhere on the rankings, probably does more hydrocephalus treatment in this little outpost hospital 5 hours outside of the capital than maybe any place in the world. That place is where a very important treatment protocol was refined, developed, where does anybody hydrocephalus is? Everybody knows what hydrocephalus is, right? Because we're out of medical school, right? Okay, so cool. Okay, so yeah, so now this is the part. It's funny. Well, normally when I do this, I'm not talking to a room full of people that are like part of a university setting that's health. So now I'm going to say a bunch of things that you guys probably know. So infection in the brain, cerebrospinal fluid's going to build up. Obviously causes a lot of pressure, crushing brain matter. I mean, thankfully, kids who, their skulls haven't fully formed, their heads expand. It's very shocking to see someone, in that situation. It's actually saving their lives at that particular moment. If it's addressed quickly, the child can go on to have a completely normal life in a surgery that takes about 45 minutes. If it's not addressed, 50% of those kids are going to die before age 2. The other half are going to live with very, very severe disabilities. So we actually started doing work in our hospital in Uganda back in 2000, where we used the standard treatment protocol, which is to put a shunt, flexible tube, into the head in order to help relieve the pressure. The problem in the developing world is that you're basically putting a time bomb in the kid's head, because even though it's really good because you saved their lives, we know that that shunt's going to fail. It's going to fail maybe 3 to 4 times throughout your lifetime. And when you live 72 hours from the closest neurosurgical facility, it's good. We're extending your life. We're not saving your life. So we started working with a treatment protocol with flexible scopes called ETV, and then combine that with the cauterization of some of the glands in the brain in order to basically slow down the production of fluid. And we've got all these longitudinal studies that say, we'd argue it's a better way to treat hydrocephalus, right? So the person who authored that is now the head of pediatric neurosurgery at Boston Children's Hospital. They do more of those procedures than anywhere in the United States, which is about 27. We do about 950 a year at our hospital in Uganda, so people come to Uganda to learn how to do the procedure. So suffice it, so we've got a network program where we bring in surgeons from developing countries, or we're actually training academic pediatric neurosurgeons in the United States, in Uganda, on how to provide this care, and then send them, if it happens to be a less resource environment, we send you back to your own country with the equipment and partner you with someone who actually does follow-up care. So suffice, okay, so major focuses, we treat a lot of orthopedics, neurosurgery. That's her in the picture on that side. That's her now. A lot of reconstructive surgery from kids that fall in fires, as well as cleft lip and palate. And we also do infant delivery and maternal care in places like Afghanistan. Another thing that's interesting about us as an organization, we've got a really strong focus on technology and innovation. So if you go check out our website, it's great. In fact, it looks a lot better on your phone, I think, than even it does on the desktop. And so there's a strong focus on sort of leveraging technology to communicate what we do. For years, we've been we're the largest organization in the world that does the kind of stuff we do, and most people don't know that there's a pretty arguable statistic that says there's about 100 million kids in the world that have surgically correctable conditions, right? So since we're the largest provider and we don't ever take any time to talk about it, that doesn't really help the cause of essential surgery. So we're trying to be more intentional about that. You can find out more on our website. Okay, so all that's context just to understand, it's 20 years, a lot of growth pretty quickly, and not a lot of focus actually, prior to 2010, 2009 at all really on technology. I was the first technical person the organization ever hired, really. Okay, so I'm going to give you this just as a last kind of, this isn't a feel-good story. I mean, it is a feel-good story because it's awesome. We get a chance to help kids like this, thousands, tens of thousands of them every year. But this is WinJoy, just as a direct example. So encountered her in June 2011. Obviously, some severely bowed legs, and we're able to actually record what happened before, during, and after. Right? Okay. So surgical intervention, radical impact in that kid's life. It cost us a few $1,000s in order to make that difference for her and her family. Right? Pretty sophisticated from an operating theater perspective. If you've ever been engaged in developing world medicine, there's a good chance you've never been someplace like a Cure Hospital. It's a very different sort of environment For a lot of the stuff we treat, like I have a 3-year-old and a 4-year-old, I let our docs cut my kids in our ORs, like if they had the conditions that we treat. So, yeah, so I talked a little bit about like the hydrocephalus work. That's actually the guy right there, Ben Worf, who pioneered that procedure. Not only are we doing groundbreaking work in hydrocephalus, but like very like significant studies in like clubfoot treatment, and done some stuff in Southern Africa on like the social impacts of essential surgery and what kind of impacts it has on the individual and on the family. A lot of that's been published. Okay, so we're 1,500 employees around the world. This is where it gets tricky. There's 5 of us on the tech team. Okay, so we're that was 5 more than existed 5 years ago, right? So we're dealing with some pretty severe resource constraints. Okay, so back in 2011, this was what we encountered as far as like what we were doing from a record-keeping standpoint, right? This is not that uncommon. Good for us that we're keeping medical records on everybody that we're taking care of. In our hospital in Kenya, which had existed, actually it's existed now 18 years of first facility. We're, just this giant backlog of patients. And because we're running a surgical facility in one part of the country, we run a network of clinics around the country where we do like long-term identification, follow-up with kids that can use the services that we provide. So this is generally how this is our transport layer for information, right? We load these tubs up on top of whatever vehicle we're going to take out to a mobile clinic, and like we dig through those records when somebody shows up to get for a follow-up appointment. Okay, so obviously we had a need for an EMR for some sort of hospital information solution that would help us solve some pretty significant problems. And we're not the only ones. So there's no really good data, and actually maybe somebody in this room knows this, and if you do, please come talk to me afterwards, on the question, like how many hospitals are in underserved countries, low to medium, like what are categorized as low to medium income countries. So we took data from the UN and WHO and tried to mash that up and said, well, we think the number's like 14,000. But it's a lot more than that. And we actually can't quite know that because one of the groups we're working with claims they think there's 30,000 of them in Nigeria alone, right? So whatever the number is, it's significant, and we're not the only ones that are struggling with this issue of like how to actually implement EMR. So what we did is we went and looked into the issues of like, what could we do like from what we know right now related to like Western systems. So we looked at, Western healthcare solutions, existing open source platforms, and then this notion of trailblazing. What if we do something else? So I think since given the subject, everybody knows what this is, right? This 7-level model of EHR implementation in hospitals. And we asked ourselves a question, like, what are we trying to get to? Everybody else probably also knows that number on like IT staffing is either measured based on the entire employee count or the number of beds, right? And so for us, like we were looking at like traditional solution, let's assume that we don't pay attention to the fact that we're a distributed network, that we need at least 30 to 50 additional bodies on board to sort of like approach the problem in a more like traditional sense. We could argue that down a little ways, and I did try to argue it down a little ways, but ultimately it falls far outside of our means, right? So we're an organization that like we do about $70 million worth of care annually. We're raising about $23 million of that in the United States. All of us work like below market rate, right? But at the end of the day, like it's not sustainable, including our CapEx expenditures on the type of hardware we need, even if someone were to give us something for free. Just in case you don't know, this is about what the average hospital, if you average it across the entire United States, is spending on EHR as a solution, which falls way outside of my budget, shocker. And I would say like one of the things that's interesting is that this is, at the end of the day, this chart's actually like noting what's happening from a venture investment in digital health solutions right now. $4.5 billion is nothing, right? But it's quadruple what it was just a few years ago. It's a real, we all know, like, healthcare is a really complicated place to, particularly for the software industry, to come in and like start to actually like drive innovation. But I think it's an inevitability. I mean, there's like, we're going to get to better solutions long term. So for us, we went and looked back at like what kind of business requirements are we looking for. I'm not going to walk through every single one of these bullets, but most of these things should be like should be pretty obvious to a lot of us. We've got different requirements than a more sophisticated facility, but they're like somewhat analogous. And ultimately, we're not just tracking patient records. We actually need to manage the business of what does it take to deliver this care. When we put in a pharmacy order, we need to make sure that we actually have that drug on hand so that we're not spinning our wheels wasting time ordering things that we don't have. And one of these items here, we've got two sort of very specialized requirements. The solution for carrying patient records into mobile clinics, and we've got a sustainable total cost of ownership. Any questions so far? I'm sort of blazing through, but nobody's asleep yet, so that's good. Okay, and then some additional business requirements. We want to implement a quality management solution, and long term, we need some optional support, like nursing support. When you talk about developing world healthcare delivery, a lot of times, like for a hospital, the notion of like a nurse interacting with an electronic system may be like a bridge too far, but you still want to have the opportunity to sort of grow into a solution like that ultimately. And then we had some technical requirements. We wanted to go with a browser-based solution because we want to not have to install a bunch of software. We need the capacity to continuously upgrade the system. We want to remotely monitor it. We want to measure the change management in days, not weeks and months. We want some traceability on the data and what's happening with updates. We've got an internal requirement that we use Google as our authentication source for everything we do, so we wanted to make sure we did that. So roll through all those, just finally to say, so we looked across the potential options, and it was clear like we weren't going to move with a commercial system. We weren't going to be able to go with an existing open source solution based on some of these technical and business requirements, particularly around the way the system's hosted, the way it's upgraded. And then started looking at some work we had done previously in record keeping with the hydrocephalus program. So earlier I talked about we do this training program in Uganda. One of the things we do when we ship a physician back out to their home country is we equip them with a research database that was using some pretty innovative technology that worked even when the internet's off, right? So it's a cloud-based solution that does this. What if we borrowed from that and actually started thinking about a new solution? And what if we managed it more like a product? So there are some significant challenges, obviously, of working in extremely resource-constrained environments. One of them is connectivity. So most of the environments that we operate in, like the low-resource environment, and this is in Kenya, actually, which Kenya, like by comparison, actually has plenty of resources compared to some of the places that we operate. And there's two different challenges you're dealing with. It's like the reliability, the availability of the connectivity, and then the reliability once you get the connectivity. So the optimistic part of the presentation is to say, when I started 6.5 years ago at Cure International, it was really, really terrible. Now it's just awful. But it's getting better, right? Like 5 more years from now, it won't be acceptable, but like we'll be closer. Some of that comes from like lack of competition. There are countries like Ethiopia where the entire telecommunications infrastructure is managed by the government, right? So the government doesn't do that well. Let's not talk about whether or not the government does anything well, but the government doesn't do that well, and so there's no competitive like landscape. They shut everybody else out, and so there's not a lot of opportunity. Kenya's getting better because there's a lot of competition, but it's a definite reality. So a lot of people would approach that and say, like, well, since connectivity is a problem, why would you go to the cloud? We decided to turn that on its head, and I'll talk about that a little bit more in a minute. Also, the challenge of working in developing countries. So developing for us equals shifting environments minus the resources to support or enforce the change. So there's some pretty significant challenges, particularly as a lot of the governments that we're operating in, so like I'm speaking in generalities, right? Everybody's a snowflake, but the challenges that we encounter often are that there's people looking at, like, say, a Western context, some of the very good decisions, or, you know, arguably, right, good decisions that are being made there, and trying to emulate those things. That's a positive. Not having the resource to support that implementation, nor the resource to oversee it, is the kind of challenge that we run into. And as an organization that's trying to it's trying to play by the rules, like, it's a significant challenge. So what's working today may not be working tomorrow. And then just educational and workforce limitations. Just as an example, we opened a hospital in Niger in 2010 in Niamey. Does anybody know where Niger is? It's in West Africa. There's a river, and there's a lot of desert, and then there's the capital city. We went through that when we were going through the hiring process. We couldn't find a single nurse in the country that we thought was really qualified to work in our hospital. So we're investing a lot of time and energy in training people with raw skills, like to be able to work in the setting, like to be able to provide safe surgery in a setting like that. So that's another thing I didn't mention. So we're 1,500 employees around the world. Less than 100 of us are Westerners. Like, so this is not an organization of the West coming to solve problems in the developing world. It's a partnership of people that are working towards one common goal, which is healing kids. So we recognize we're going to have to spend a lot of energy training local nurse talent in what it means to operate in our facilities and to do that well, which we also know means that we're going to be feeding the local environment, because those people are going to capture a bunch of skills and then move on to a job that's going to pay them better than we will. But we find some segment of them that are sort of on board with the mission, and so they choose to stay. Which is just to say, in a setting like that, adding on top of that now, like, some capacity to be able to work with technology solutions becomes more complicated. It's equally so when you talk about IT talent in a lot of these settings. So part of the reason that we sort of dropped out, and I think part of the reason that a lot of other open source solutions haven't worked, is because IT talent's so valuable in a lot of these contexts. So the market may belong to me, like in the United States, as someone with experience and time working in the technology field. It's like monumentally more for someone who's really qualified and capable of doing that in an environment where there just aren't a lot of resources, a lot of people resources to do that kind of work. So the notion of attracting that to healthcare, let alone charitable healthcare, is pretty difficult. Not impossible, but like very, very difficult. So that's another constraint that might cause you to curl up in a ball and decide not to work on the problem at all. And then we also have the complexity of, like, in an environment that's like highly driven by insurance reimbursement, the notion of prescribing what someone needs to do for the purposes of getting paid, like, is like a pretty good stick, right? We don't have any such scenarios. I mean, across the board, really. I mean, particularly because we're a charitable organization. But like the insurance structures, national or private or otherwise, in a lot of these areas, they exist and they're sort of coming online, but certainly not to the sophistication that we have in this environment, or even in other single-payer systems. So you've got another constraint here: limited financial incentives. So our four connectivity, developing economies, educational limitations, and then limited financial incentives. But there's some really good news, at least I see it that way. It's that there's a lot of opportunity. So we've been really focused on this notion of judo flipping the constraints, because we think we got a pretty good, smart people overall, not us. I'm not the smart people, but like innovating has a pretty good track record. Does anybody know what this picture is? This is one of the great engineering marvels of the United States. It's like 1850, 1860. It's the whole process of them actually lifting the city of Chicago in order to like help create a sewer system. If you ever want to this is a really fascinating read. If you ever want to check this out, the city's flat, and they actually created a grade in the city by lifting buildings and resetting them. And it's very much like an open source project. Honestly, there's about 600 people with jacks that are all turning one crank at a time to lift a portion of an inch as they're sort of slowly lifting this thing. It's kind of interesting that there's actually people in the building while they're lifting it. And they lifted whole city blocks, right? So taking the constraints and doing something very innovative. Actually, some of the techniques that were used to support this is part of the reason we have the Panama Canal. So, because they actually had to build whole new digging equipment in order to make some of this work. Because they eventually reversed the river too. There's an opportunity to drive fundamental change. It's another opportunity. For this, I'm going to point to one of my favorite telecommunications technology companies on the African continent, Econet. So there's a lot of opportunity in developing world context because that solution hasn't shown up yet to sort of help drive the way it's implemented, right? To do things well. Econet's done some, in a context where a lot of people would say they're based in Zimbabwe, right? So you want to talk about complicated economic circumstances, try running a commercially viable telecommunications company in Zimbabwe. But they're bringing some really interesting products to market where even they bring connectivity to your home. They actually have got these sort of connected home services that tie in with a health service that they provide, which will actually, not only is it doing things like delivering health tips to pregnant moms, but it also has the capacity to do things like tying a blood pressure cuff to a SIM card and be able to fire that back to a physician that's able to help diagnose you while you're sitting in your home. So some cool opportunities, leveraging what's been learned to define the future. And then there's an opportunity to shrink the delivery cycle. I try to put some humor in here. One of the things we wanted to do is create a scenario where the point at which we noticed an issue, right? So we noticed a need to how we could deliver it became very, very small. That's one of the fundamental tenets of a lot of software business and modern software businesses. It's a mistake to assume modern trends in software business are about the technology. It's not. It's about the delivery cycle and access to the data. So what we're trying to do is create systems where it's possible for us to respond quickly and to not just take your word for it on what you said you need, but to actually look at what you did as the basis to define how we could help you do that better. That sounded more big brothery than I meant it to, but I hope you understand the concepts, right? So there's a term in software engineering, we say users lie, and that's true some, but so we also saw a big opportunity to be able to make usability the #1 priority. So in a setting where you're dealing with extreme resource constraints, we're not in a setting where if we launch into an EMR implementation and it's not going well, there's no cavalry that's going to come in and help us consult our way out of the problem. It's going to sink or swim based on the plan that we've got, the resources we put around it initially, and just the quality of the product. So we're hoping not to build teapots that'll burn you. There's also an opportunity to capture some really significant data. So this is a data analysis tool that we use on a regular basis in order to measure trends around what's happening on our website. We're integrating that exact same experience into HospitalRun as a solution. Actually, it's based. The engineering team for this is based right here in Portland. And then finally, we really want to embrace a concept that's becoming more and more popular in modern software development, which is called offline first development. So in my industry, we've been really lazy for a while, and because basically there's ubiquitous connectivity, we just build everything with the assumption that you're always connected. The reality is, like, we're dealing with constraints where we have to assume that you have connectivity sometimes, but where could be significant periods, measured in minutes, potentially hours at times, where you don't have connectivity. And the argument, actually, like across the software industry, is that we should be trending more towards this as a pattern, because the reality is we've all experienced that moment that you go into the subway and then all of a sudden your phone doesn't work on something that seems like it should have been like completely functional. Obviously, you can't assume you can connect to the internet, but why is my app breaking? Why does it treat offline as an error condition? So great news, modern browsers have both frameworks and tools built directly into the browser that'll help you do this well. And we've got about 5 years of experience, 5-6 years of experience doing that kind of work. And then the biggest thing, this one that I'm really passionate about, this comes from a talk a couple years ago. That guy happens to be on our board. But the focus was, like, what can we as technologists do to give people back their time, right? So by building systems that are easier to use, would it be possible that you'd actually, like, offer people back the only thing that we can't make more of? And we think there is some good opportunity to be able to do that. And we're plumbing the system, actually, in order to be able to measure that. Okay, so this is the talent portion of the presentation. So I'm going to share a couple technical details around the open source solution that we're working with. Okay, so first of all, this is the homepage for HospitalRun. I would encourage you to go check it out as a project. Maybe tweet about it, because maybe you want to get involved, because we're looking for lots of people to be involved. Maybe you know somebody who wants to get involved. HospitalRun.io. And we're embracing both that usability piece as well as that offline first functionality. Okay, so this is test data that I've sort of modified in my development environment, but like this is an example of like what we've got in the patient screen. And there's some really cool things that are going on with two-way data binding where all the information, I shouldn't have said that. I'm sorry I said the word two-way data binding in a talk like this. Anyway, so there's some really interesting things that are going on with the way we're capturing this data, cataloging it, and presenting it. And this feature, actually, what we're doing with patient history and clinical notes comes directly from feedback that we had from our very first deployment in the Philippines. Just another example of like a few of the screens. This is the slideware section of the system. So searching through appointments, looking through the list of admitted patients, another patient edit screen with coding like for congenital clubfoot. So this just as so how do we do this from a technical deployment perspective? This is where like sort of it's possible to use the technology in order to do something really interesting. So this is the nerdiest slide I'll have. This one and the next one. This is kind of like the core setup that we use when we're deploying HospitalRun as a solution. So you've got all these endpoints that are interacting with the system, and then what we actually have is an appliance computer that's running internally in the environment, like so pretty low-grade hardware relatively, that actually is running the system. And then outside the firewall, we've got a cloud instance that it's connected to. And we use a piece of technology that automatically gives us the data replication over secure lines. And then we also have the capacity to integrate with things like a PAC service. Because of the offline first nature, all these systems are actually the ones that are running HospitalRun. So as I download the system the very first time, I've actually got access to kind of the entire breadth of functionality in the system. And so the whole way the system is actually built is so that if I'm connected to the internet, I'm always talking to the server, whatever the server means. If I'm outside of the facility, that's the cloud service. If I'm inside the facility, it's the appliance service. I don't really understand like what the difference is. My machine doesn't need to know anything about where I'm actually at. And then if I lose connectivity entirely, I can actually use the offline first capabilities in order to still interact with records. Does that kind of make sense? Like as a concept, okay. And then just a couple more things here. The early results. So like what have we actually done with a solution like this so far? The stars mark the places where we've done deployments. The Philippines, we've launched the entire system. So we're at a state right now from an open source project perspective where we haven't officially called it like a 1.0 version, where we're encouraging lots of other people to start using it. But we're using our hospital network as kind of the guinea pigs. I have the advantage of running an open source project where I'm directly connected to users who more or less have to do what I ask them to do, and getting pretty favorable responses back so far. And just this week, we have a partner who launched it in 8 hospitals in Guinea, knowing that it kind of wasn't, we don't think it's ready for prime time yet, but where they wanted to start capturing user feedback, and they've got the resources possible to do it. So just to say, like, we're kind of picking up momentum from an open source project perspective. We've done about 1,000 patient records at our hospital in the Philippines. So I mean, these are relatively small facilities, doing somewhere between 1,000 and 2,000 procedures per year. And that's all I had to share about that. So if you guys have questions, you'd like to talk about like some of those challenges, the constraints, maybe what we're doing as a project, I'm happy to talk about those things. So.
Thanks very much. This is pretty exciting stuff. For those of us who have been implementing expensive vendor EHRs for a long time, it's nice to see something actually moving along in this space. In that regard, there's within the U.S., there's about 700 critical access hospitals in rural communities that are all facing bankruptcy right now, with huge IT expenses that they can't maintain. Do you foresee a time when you could take your product and start implementing it in resource-constrained areas of the United States?
Yeah, so sure, because there's a lot of things that could happen in the future. One of the things we're really focused on is making sure our product management is very tight for, so a lot of open source projects tend to operate as a giant do-gooding activity, and that's good. Like, there's been a lot of really positive work that's gone on with that. Developers tend to only contribute to things that help developers, but once you get past that and you can kind of build some momentum. One of the mistakes I think that's happened with previous attempts like this is that there's been sort of too broad of a focus initially. So we're going to build a health system that could replace a commercial platform. No, that's kind of too big of an item to bite off. Getting to the place where a solution like this was feasible for the United States, I would say anything's possible. It's not really a focus of the project right now. But yeah, I mean, I think my bigger hope would be if we were really successful at what we did, it would drive innovation from more resourced companies in markets that are like this already. So yeah.
So to what extent are you building in international healthcare interoperability standards, such as ICD-10 and others into this?
Yeah, so the system's it's plumbed, it's got a really nice interface for how you interact, at least we think so, as a clinician interacting with ICD-10. Particularly, we borrowed some technology that is used in the Twitter type ad in order to basically be able to consume and digest the entire coding standard and do pattern matching as you're typing it through the system. So we're trying to create some scenarios where actually doing accurate coding is not painful. It doesn't require you to click through 6 or 7 different screens, nor does it require a ton of setup work. So I'm going to make a point that isn't about your point. But one of the big things we're focused on is what could we do to help support one change agent in a facility to get people on board with the notion that we ought to be storing this data electronically. And so one of the things that requires is sort of this product development perspective that says, like, you need to be able to lock things down long term, but in the near term, actually, people just want to start using the system. They don't want to populate 100 type fields in order to just, like, sort of enter the first patient record. So we've got a lot of those types of, it's meant to sort of drop the friction in the onboarding process, and then allows you to turn around in the administrative panel and say, okay, we're not letting people edit that anymore. Like, we're going to clarify where we're at with the data, and now we're ready to, like, get more sophisticated. So anyway, we've got a strong focus on being able to, particularly when it comes to coding, be able to implement those types of standards. Of course, it gets complicated depending on the environment. Like, which version of ICD-10 you're, like, using can change, and so I would say honestly, like, we're still sorting out, like, some of those issues, but it works actually really, really well right now. So, yes, sir.
I guess this piggybacks a little bit on that. I have two questions. The first one is, are you adhering to kind of internationally accepted data standards like HL7 or FHIR or anything like that?
Yeah.
And then the second question is, going back, you had a slide in there about deciding whether or not to use a commercial solution versus an open source.
Yeah.
Obviously, OpenMRS has had some success and has been deployed in different areas across the world. Can you speak to why you decided in-house solution is better than taking something that was already out there?
Or an alternative open source solution, because it wasn't in-house. Like, so we're driving it, right. We're leading an open source project that's, like, so this would be a giant failure if we're the only people that ever utilize it, which is one of the reasons we're encouraged by the fact that more people are onboarding. Yeah, so, like, I'm happy to answer that question. So I always want to make sure, like, I'm careful. Like, so I am not interested in bashing work somebody else has done. I think there's a lot of good people doing good work on OpenMRS. I think that the fact that the project has existed for more than a dozen years and this is still a gigantic problem might demonstrate that the problem's more than just building a piece of software. That the issue is actually more about the entire onboarding process and actually creating an open source service that would be possible for anybody to, like, have access to, right? So if you're, permissioned the appropriate way. So I think, like, part of the issue with deployments like that, one, there's, like, they have a hallmark of being built by engineers who didn't care about usability, which we're seeing across the industry. Like, that used to be okay in 1996, and if you're a company that does things like that, eventually the market's going to eat you up because someone's going to figure out not only a cheaper way to deliver it, but a way where you actually get the lower level users clamoring in order to get access to that solution. So usability is a pretty significant issue. But the actual mechanics of how a solution like that is installed and administered and upgraded long term is another sort of systemic reason we decided it wasn't. We looked into the notion of, like, could we walk into that community and help push it forward in a way that we thought was better, and ultimately determine, like, the friction there was just going to be, like, too significant. I mean, particularly when it comes to the offline first requirement. So if solutions like that tend to walk away from the cloud because of that connectivity issue, rather than accommodate for it in the way the design's implemented. And so we're sort of thinking at a root level that that's one of the core things that we want to embrace, which is it should work even when the internet's off. So, but we would like you to actually host it on the internet, so, or on some sort of private cloud. So, yeah. Does that make sense? Yeah. Yeah.
So it was a really great talk. It sounds like great work. I really enjoy sort of the this cloud-based approach, and it seems like things are very streamlined and user-oriented and that kind of thing. I was wondering, for us, a lot of us being researchers in informatics, when we look at the spate of problems that's out there, some of them can be solved by something that's just a simple reorienting of how you think about something, or focusing on users or something like that. I'm wondering if you think there are also remaining challenges that are sort of like big challenges that researchers might need to tackle, but are still have a significant impact, right? So that it's not just this was a big problem, but all it needed was this different perspective and different solution.
Yeah.
Are there still challenges that are like this is a significant thing that we need to get some research minds at?
Yeah. Okay, so that's a big question. So I'm going to say something that makes me sound like I'm more of an expert about this topic than I am. So for us, I think one of the challenges is long-term, a deeper level of instrumentation, and integration with a lot of the devices that we're working with. Not just in capturing the data off those devices, so the blood pressure cuff or whatever, right? So that it's not for us one of the big challenges that are out there is maintenance and repair of a lot of those items becomes a pretty significant challenge, and there's a lot more that if those devices were sort of built in a way that was able to sort of make other systems aware of their health, that would be a big benefit, particularly for organizations that are working in pretty resource-constrained environments. For us, I mean, a common thing, I mean, you see it very, very, very commonly, is that great equipment gets shipped someplace, but nobody's there who really knows how to take care of it, or there's sort of no internal capability in a lot of those pieces of equipment to tell people when there actually is a problem. So I think that's kind of a big challenge for us. I don't know if that was helpful. But, yeah.
So I'm curious, when you're deploying your solutions, are you targeting clinicians, patients, or both? And when you do so, are there any particular constraints that come to mind in addition to having to develop for offline services as well?
Yeah, so our strong focus, so there's a couple different, in our industry, actors that we think about. So when we talk about usability, we're talking about ease of use for clinicians, for administrators, for support staff, ease of deployment. Ultimately, actually, one of the things we're trying to do, too, is make it easy for developers to contribute code to it. So we made some very intentional technology choices about how the system's built in order to enable that. But one of the big challenges, so it's physician focused, not patient focused. Really, is that's sort of the short answer on that. One of the big challenges, that we have is always security. So it's data security. You're walking into a whole different world of complexity when you start talking about. So there's some trade-off. I need the capability to carry records out into a remote clinic location, but I've now created more attack area from a security perspective on data, right? Now, so that's one of those big challenges that we're walking forward with some smart decisions, including the determination that you could just decide, well, I don't want any of the offline services to work on the system. We're going to just use it internally in this facility. But I think that's probably one of the biggest challenges.
How much thought have you guys given to not only making a system that's going to be good for clinicians to use so that they can access all the data, but also it's more of a data or a research kind of data warehouse.
Yeah.
Where you can actually take the data that you're collecting over the years and say, okay, this is what we did 5 years ago, this is what we're doing now, our outcomes have improved by this amount.
Mm-hmm. Yeah, I mean, so the technology we're using for data storage creates a lot of opportunity for that, and it's it's also one of the reasons why we went with a solution like this. That capacity to be able to roll information up in an obviously transformed, like totally different, more consumable form, is one of the focuses of the project. It's not a feature in the system at the moment, but it's a big focus of the project.
Could you tell us a little bit about the evaluation of the project? Are there people actually doing that? I mean, obviously, there's good uptake, but then once a hospital has implemented, is there a plan for evaluating success?
Yeah. Developing, yes, there's a plan developing. So there's two different connection points. Right now, we're at a stage, so in our open source project, we're looking to deploy in our existing hospitals, as well as starting to work with a select set of basically beta customers for the solution. Specifically because developing that evaluation plan is one of the tasks that we have in front of us before we'd say, hey, we think anybody should give this a try. That's part of it, but I also think part of focus on a cloud-based solution is that we're actually plumbing the system with a kind of in-application analytics that helps us evaluate things like what are users getting stuck on, how much time is it taking them to accomplish task X in the system, and we can measure that information and judge ourselves even release over release on those types of things. So there's definitely an interview, there's an interview piece and an evaluation of data quality that needs to find its way into the project. There's also a lot we can do from a technology perspective to let you talk to us without talking to us.
So I had just a couple of questions. I was interested to know in the most likely when you looked at the commercial solutions, so not including MRS, just by the very nature of their cost and both in terms of actual money and resources required to implement it, they were probably off the table immediately. But I was interested to know just from your other requirements what they fell short on and how you didn't feel like they would fit what you needed.
Yeah. So there's a combination. A lot of it actually was based on the type of hardware that we'd have to be able to support in the facilities. So we didn't have the capacity to be able to take care of that. In fact, we had a really generous offer from an organization back 3-4 years ago where they were going to give us their software license free, but it was going to cost us about $250,000 per location in hardware installation, which was not an unreasonable. It was a very generous thing to offer, and we were going to put, it's not a refrigerator, right? I mean, software is it's not a thing where you just plug it in and then it works forever. It's a living, breathing activity. So there are a couple other, so easy use in a lot of the features. The amount of training it was going to take for us to get to a place where we felt like our staff was comfortable working with some of those solutions, and we felt like that was a little cost prohibitive as well. And then as we've got people transitioning in and out, do we have resources locally that are going to be able to help manage that process? And then I'm trying to remember, there was a third thing. But anyway, you get kind of the point. Yeah. Yeah.
And I think maybe the last thing I would ask is, for the group that this is, since this is an open source project, if there was interest in people getting involved, what are the sort of major areas of need that you could see people helping fill at this point?
I remember what my third thing was here, okay, but then I'll say that. Yeah. The third thing was actually, so it's this, there's a trap you can fall into when there are some sectors of business problems that technology companies are sort of transferable across the board. Customer relationship management is the same thing no matter where you are. When you talk about someone giving you a piece of software that wasn't designed to work in your environment, your capacity to influence the roadmap of how that software continues to get built is zero, right? So as we encountered issues where we felt hey, we really need the system to do this, there's no chance that that's ever going to happen. So not only is the release cycle for that 6 to 12 to 18 months, but also we wouldn't have a voice ever. So that was actually the other issue. So one of the things I'd encourage if folks are interested in even just checking out the project, go to the website. From there, you'll find a link to our GitHub repo. I'm not asking you guys to write code. It's moving to, if you want to join our Slack channel, or our Slack, there's actually a subsection of people that come from more of a practitioner background that are starting to sort of like track with what's happening from a feature development perspective in the project to be able to provide input. Long term, we've got actually some needs around like sort of developing an implementation plan, right? So we hope there's a lot of things that we're building that are like pretty apparent, but the reality is like helping people plan to be successful with these things is work that we're, as now say, so it's sort of two separate things. HospitalRun is a project, Cure International is an organization that's incubating this project. We're investing resource in doing that, but we'd love more help. So that would be another big area of assistance. Okay? Yeah.
No one has any other questions?
Thanks. Thanks for paying attention.